They have a new enterprise, and it is called Family Health Center of Williamston. Is that right? Do I have the names
correct,
right?
yes.
I'm going to have you move right up on the mics, about an inch or two away, so that we can hear you. This is fascinating to me because I was happy to see healthcare reform come through in the form of Obamacare, but the holes in the program are still big enough to drive a truck through. And
Right.
what you're trying to do is, for the state, or you're really a groundbreaking here in Michigan, you say that some of these experiments have taken place elsewhere, but it's trying for a new model of family health care. Tell us a little bit about how that works.
Well, it's a model of healthcare that brings the physician and the patient back in line with each other. The relationship is between the patient and the physician, and not the patient and the insurance company or the physician and the insurance company. I think we were all excited about Obamacare, the Affordable Care Act, but you're right, there are holes big enough to drive a train through, and it's unfortunately not working. And we have many people that cannot afford it at this point. And what we're doing is we're taking the insurance companies out of the equation.
You buy a service, a monthly fee, a family or an individual pays a
Doctor's advice do not require that they're actually sitting in the doctor's office.
Right.
They don't have to make an appointment. They don't have to take time off work or take time
Substituting
out of schools,
that kind of
whatnot.
technology would be so good for everybody because, I mean, first of all, you're not bringing an infectious person into a waiting room if they've got the flu and spreading it to everybody else in the waiting room. I mean, and they know what they have. They just need to be able to access the service. How do you keep it affordable and still make a living?
Well, the overhead in dealing with the insurance companies and the government is quite high. And there are a lot of numbers that are floating around out there. The one that seems to be most consistent is when we don't have to deal with insurance companies and billing companies and the government, we can cut our overhead by about 60%. And we pass that on to the patient.
So many of the people we see in a doctor's office are really people who are filing forms for both entities, right?
Exactly.
And so they're there in order, and the fights are endless sometimes, aren't they?
Well, the fights are endless, and if you have to fight, you've just lost. Because, as I say, it takes about 60 cents to get a dollar out of an insurance company. And please don't chisel those in stone, but it's somewhere in there.
Okay.
If we have to bill that twice, we're in the red. So, and there are many times when the insurance company will make a mistake, or we will make a mistake, as simple as a decimal point in a coding number.
Right.
And it really takes the emphasis off of why it is we became physicians and what it is physicians are doing, are supposed to do, and what physicians want to do and love to do, and that's caring for patients. We are now becoming really sort of accountants for the government and for insurance companies, and it's not working, and it's gotten so bad that we now have time limits that you can spend with your patients, and believe it or not, it's down to about 7 minutes a patient. There's precious little you can do in 7 minutes, and certainly you cannot develop a rapport with your patients that is trusting and caring in 7 minutes. And if you have to wait a week to get your 7 minutes, that compounds the problem. And then there's the insurance companies deciding, well, we don't want you to use this medication for this patient. We want you to use another medication.
Bill went through that.
Okay. And with the membership in our direct primary care, and I say I'm talking about all of the physicians out there that are stepping up to the plate and trying to take medicine back. Not that we want to do away with insurance companies. We just need them to leave primary care alone and build around that,
Right.
in the specialty areas where they really are needed.
And that saves everyone money, because I know when you go into one of those specialized ready services, boy, do they find ways to bill you.
Yes.
Absolutely.
I'm probably getting in trouble saying that, but I've had some experience of people I know that why did they do that? That wasn't what you're
And the fact of the matter is, most common reason going for urgent care, some acute viral illness, acute pain, whatnot, after hours going to an urgent care, spending 3 to 5 minutes with a physician assistant or a physician, that actually bills at a higher grade than primary care doctors providing the same service in our clinic. One of the most common reasons someone goes to an urgent care in many instances is they have no ability to get into their primary care. I have the sore throat now, but it's going to be 3 weeks before I have any access to care.
And the other issue is the person even in the emergency room. I mean, my husband once had a problem, ended up in the emergency room. He got a bag of saline, a diagnosis, and it was $3,000.
Right.
He never spent the night. I mean, and you think that's a
Exactly.
lot of money.
Yeah.
If he had been able to talk to a physician with whom he had a relationship, that person might have said, "Oh, and you had that big ice cream sundae? That might be part
Right,
of it."
exactly.
Or in this model,
Right, exactly.
they would be able to meet us at our office after hours or on
Yeah.
the weekend. We know what's going on with you, Mr. Jones. We've been through this before.
Yeah.
Let's save that visit to the ER for something that's really an emergency.
Right.
We can give you some fluids. We can help you administer your insulin to get your sugars back under control. It's hard to not see the benefit of that if
And so often, and it is true that there is over-testing simply because the person has you may take a history from somebody, but you have no real opportunity
That's the difference.
to understand it and put it
That's
in any
the
kind of
difference.
context.
These are patients that we've known, personally I've known for 20 years. And now
So you switched out of this
well,
system? Wow.
we have a practice in Williamston
Uh-huh.
that we've had since 2000,
Okay,
but we're now changing it over from insurance fee for service, if you will, to direct primary care. And because it is considerably cheaper, because we can offer much more at a much lower cost, you had mentioned that it should be a savings across the board. That suggests it would save the government about 40% if we can get this moving and keep this grassroots phenomenon, if you will, moving. And there's a lot of numbers thrown out, but I think everyone would agree that there's at least 15,000 direct primary care physicians out there now practicing successfully. And nationwide.
really, that's all?
Well, but it's growing every day, and some numbers are as high as 30,000. It just depends what source you look at, and that's not accounting for the concierge medicine that the people that are fairly affluent
Right.
get. This is that idea, but for everybody else,
Right.
so that you get to see your physician, and it's 9:00 at night. And something happens, as you mentioned, to your husband, and he gets a bag of fluid and they send him on his way. Well, he would call us. We would meet him at the office or go to the home. We do house calls as well for those that are in need, and we don't charge for that. That's all in the membership.
May I ask how...
I almost had a heart palpitation when he said house calls. Can you imagine being able to get a doctor in to see a kid who's sick?
I
That would be
know.
pretty special.
That is. It is. I'm sorry we lost that in the culture.
And we have lost that in the culture, and that's what we're bringing back, along with, dare I say, real affordable health care.
Right. Well, and I think you were telling me that your rates are, $50 a month?
It's
some cases?
age-based.
for most adults it is $50.
Yeah, and for 45 and above, it's $65.
Okay.
And for children between infancy and 19 years of age, it's $10 a month.
Oh my goodness.
And you just pay that every month, and it's not the beauty of this is one of the beauties. There are many beauties of this, but one of the beauties is that if someone is late on their monthly payment, we're not sending them away. They don't have to wait till next year to catch up. We work with them. We're their doctor,
Right.
and that to us means something different than it has meant for a long time.
We've been trying to work our way back to a family medicine model, but there
Right.
have been all these incentives that are carrying us away from this into specializations.
Right.
I mean, if you want to be a physician who can drive, a Mercedes, you're probably going to have to become a specialist. It's not that lucrative a field.
It's becoming quickly a profession where if you want to keep the lights on, you'll have to increase your productivity,
Yes.
take your 15-minute appointments down to 7 minutes
Yeah.
so you can fit twice as many people in. We suffer through reimbursement cuts and the ever-looming Medicare restructuring, and
You're so vulnerable to all of that.
it is, and we're at the very base level, and primary care, and family medicine in particular, seems to absorb the majority of that. It's made it a very undesirable and unfortunately one of the lowest paid
I have a
specialties
friend
of medicine.
who's a specialist in hospice care, and he said he begins to feel as though he's an employee of the insurance company and that he's not allowed to be a doctor.
Absolutely.
And that's
It's very
what's so
accurate.
frustrating.
Absolutely. And that's what we're
there are
taking
really gag
back.
orders in some of the contracts that you have for
Yes.
hospital
Sure.
privileges and so forth, where you can't speak out against them. And you can't even talk about the problems. I mean, I think it's really becoming such a corporatized system.
Yeah.
I don't know, I mean, will this be able to crack the mold in a sense? Will we see other physicians doing
We
this?
believe it will. Again, the numbers are somewhere between 11, 12, 13,000, all the way up as high as 30,000. And it's climbing every day. According to Forbes magazine, and I don't know exactly when, but there was a prediction in an article in Forbes magazine about direct primary care that somewhere within 5 to 7 years, this will be the norm and not the exception in terms of how primary care is delivered.
I would like to see institution, I work for Michigan State. One of the big complications I had was I retired and went on to Medicare, and then I went back to work and didn't realize they would just automatically change my insurance again.
Yeah.
So for a year, for almost a year, I was having bills of various sorts that weren't getting processed properly just because I didn't even know what system I was on. So part of the challenge is I would think working with employers too, who might be willing to have this as an
Absolutely.
employee perk.
It's a very eloquent system. Employers stand to enjoy many of the same and even some of the more specific perks of a practice like this.
You'd marry it with a catastrophic policy. So
Correct.
if I
Yeah,
had
major medical.
appendicitis that night and not something that could be handled, I still get that covered.
Absolutely.
Yeah, the savings, it's not just the patient. But if you have a 5-year-old who has a bad earache and you don't have to take time off work because we'll come to see you, or we can do it over the telephone, it's kind of a win-win situation. The employee does not miss time. The child is treated by someone that knows the child, and the employer did not miss a day's work from their employee. So across the board, it has a trickle-down effect that really is quite amazing, and we view it as something that has been lost in medicine, and our goal is to bring it back.
This is LCC Radio, WLNZ 89.7 here in Lansing, Michigan. We're talking with Doctors Mike and Bill Mangan, who run the family medicine, Family Health Center of Williamston, about this new form of medicine. Bill, you had a question.
Well, I think I heard on the radio today that a hospital in southeast Michigan is trying to implement something like this as part of their services. Would that be accurate?
I have not heard that. I hope it's true.
It
Certainly.
sounded like a pretty similar situation. What's the pushback you get from fellow doctors? Is there any?
Well, we get a lot of kudos for what we're attempting, and when we describe to them what we're doing, we get sort of a question mark look on their face that suggests, I'm thinking this might work for me as well. And there are very few doctors out there, if any, that like the way medicine is going. They do not like to have to chase a patient out after 7 minutes. They want to be a doctor, especially primary care doctors, because we aren't paid that well. We do it for different reasons.
And if you don't take care of them the first time, you get them back.
Well, that's true. You get them back, but we want them to get the proper care first rattle out of the box.
Yeah, because
And so I
by
truly
your
hope
model-
that's true.
By your model, spending the extra time to make sure that they don't need a second visit is an advantage. Under
Yes.
the existing system, having them come back every day would be the best bet because you could bill every day. You see what I'm saying?
Right.
The incentives are all wrong in the
Right.
existing system.
Right.
Is there an opportunity for government to embrace your model, or is that
Absolutely. This, like we've been saying, this is kind of a win-win. We can decrease the spending. We can decrease the amount that it costs to get lab work, the amount it costs to have any radiology or have physical therapy or any other ancillary services. We've been able to privately negotiate these prices on the free market. We're not contractually obligated by our insurance carriers or by Medicare or Medicaid. This is basically just a game of driving the price down, and the patient wins. We get the best price for our patient while getting them the care that they need. So better care, less spending, more time for our patients.
You must
ultimately.
face challenges, though, in trying to identify which other specialist to refer somebody to with some kind of special condition, given the fact that nowadays isn't that mostly insurance dependent?
Very much.
How does that work? Because I
Well,
never understood
many-
this. I had a friend who has been a cancer patient.
Right.
And she was told to go to this clinic and talk to this doctor, and it was all set up, and they said, no problem. That doctor was gone on a 2-week vacation, and they said, we're giving you this other doctor. She said, are they in the practice? They said, on the list to be reimbursed? Absolutely. Well, they were wrong.
Yeah.
And so she ends up with a $5,000
Exactly.
bill. I mean, how can these things happen? And how do you prevent it?
It's unconscionable that they happen, but they do happen. We had a patient who a local healthcare facility miscoded their lab slip, and our patient wound up with a $575 bill for labs that they could not afford to pay. So we're going to bat for them to try to bring this in line, but it happens. And you talked about who we send our patients to for the secondary and tertiary care. Many times we have no choice in the matter. It's driven by the insurance companies.
Yeah.
Where with the direct primary care that we're proposing and that we're moving forward with, that no longer is the case. We can be the advocate for the patient on all levels. And there are some specialists that are wonderful in one area and other specialists that are wonderful in a different area. Mm-hmm. And we can now negotiate with them, and we can direct our patients on where we would like to see them go and why. And one of the things that we haven't touched on, and I think it's important that we do, is there's probably a lot of people out in the listening audience wondering, how can we do this? Yeah. Well, it's decreasing our overhead by somewhere around 60%. But we can't continue to see the numbers of patients that we're seeing. So we limit the number of patients that we will accept in each of our, well, let's call it a panel.
Okay.
And we have more patients than we can accept. But we have other physicians who are very willing to join us and take on this model and help out with what it is we're trying to do. And there's a critique about direct primary care that if all primary care physicians that are out there now become direct primary care providers, there won't be enough primary care physicians to take care of all the patients that are needed. And that's very fair. However, if you make or if you allow us to provide primary care the way we were trained and the way our hearts describe for us to provide care, more doctors will choose
yes.
primary care as opposed to specialty care.
Yes.
Because there's nothing like primary care.
And the fact that
it has
shortage
everything
underscores that the existing system is
working.
having too many patients per physician.
Yes.
The average physician holds a panel between 3,000 to 4,000.
See, that's
and that's it. It has slowly gotten worse. 30 to 40 years ago, it was a fraction of that. It's maybe 25% of that.
As the whole population ages, and they are going to be needing greater levels
Right.
of care, it's just simply not a sustainable model.
We need more primary care, exactly.
Would you, for example, be able to take this model into nursing home or memory care?
Oh, good question.
Extended care?
Yes.
Wow.
Yes.
Because when you said the word advocate, that's really a lot of what's needed in
Right.
those treatments.
There are some models, for example, in Arizona, that I'm familiar with that are sort of on the direct primary care, the membership type model. They're not quite there yet, but there isn't any reason that this model wouldn't work in those situations. And with an aging population, again, it's a win-win situation for patient, doctor, and the economy, if you will,
Yeah.
because of the savings and because of the better care that patients, the elderly, will be getting, and more people will be willing to do it. It's hard to get them to do doctors to do the jobs now because of the struggle we have with practicing medicine in what we would consider a proper manner.
It's unpleasant. I mean, many people a lot of doctors have told me privately, it's not the field that I went into.
No.
And it doesn't allow me to do the things I want to do. One of the things I was reading just recently was that the invention of the HMO was the idea of reforming medicine to be able to give greater attention to each patient, more care, more preventive medicine, so you'd have a long-term relationship. But it was very quickly corporatized into we'll just make it cheaper. We'll make it as a cheaper alternative. So I think part of the challenge for you is to hang on to the model and not let it become part of the problem again, because it seems like a lot of good ideas end up getting co-opted somewhere along the line. Can you maintain control?
We can if we try. The idea of building our practice and maybe satellite practices and then franchising would have to be totally off the table. That's not what it is we want to do. We want to help others. We want to and take our vision, and again, when I say our, I mean the doctors that are already out there doing it right now, and help other doctors sort of mold into this type of practice.
Are you still accepting new patients?
We are.
You are. And are other doctors in the area considering joining you in this revolution?
Well, we have had contact with physicians in counties on either side of us. Some are within a few months of starting their practice. So
does it take
basically
any
a few months behind
regulatory
us.
changes for you, or any changes with your malpractice insurance or other things like that you have to be concerned about?
Well, as far as the malpractice goes, that may actually decrease as part of the overhead. We're going to see fewer patients. Malpractice is generally volume-based. So in that aspect, one of the many ways we can trim down the fat from our overhead and basically keep things as streamlined as possible. But there are doctors who are starting to call in and starting to ask, how does this model work? Where did you learn about this model? How are things going for you?
When did you learn about it?
We learned about this right around 12 months ago. We've been researching long. Have we been looking for a alternative to the status quo of the flow of medicine? And
Is there a med school or a state that's
good
really behind this kind of approach, or active at least support?
one of the strongest proponents would have to be where we learned about this, through Atlas MD in Wichita, Kansas.
Really? Never heard of it.
They have been practicing, a group of docs, now 3 strong, flourishing in this model, have been just greatly beneficial to us and anyone else who seeks out their counsel. They consult for free. I stumbled upon this through the American Academy of Family Physicians website. Went on a link, excuse me, found out about the model. I sent a kind of a vague email and got a phone call, which I was a little surprised about a half hour later, from Dr. Umber, who is the one of the founding physicians in that practice. I thought, well, that's kind of curious. The owner is calling me back within a half hour. I looked into it, and within about 15-20 minutes of just basically kind of an epiphany, that kind of light bulb going off moment. Well, you don't accept insurance. You don't have to deal with these regulations. You've cut through all the red tape. How did that work? I have a practice myself. How would I change into what you're doing? Basically, that relationship grew through that initial phone call. We started researching, and basically we're changing and revamping.
There is a special sort of purgatory for being on hold, waiting for the insurance company.
Yes.
It's only on my list of things that are, the 7 circles of hell. I think the only other one is when it's for the computer, but it's, something's gone wrong. I think this is a wonderful idea. I think this is revolutionary. I'm so glad to see that we have this in the community as an option for people. And I know when they want to call in, it's going to be the Family Health Center of Williamston, and this is called Direct Primary Care, is this movement. It's direct primary care. I'm sure we'll be talking about this again frequently, and I hope to get you back soon to tell us how this is going.
We would.
Absolutely.
We'd be glad to.